acute heart failure or cardiorenal syndrome for the next 10-15 minutes. Well, as you know, a patient who comes for acute heart failure to the hospital will have three options in terms of kidney function. Whether the kidney function will get worse, the serum creatinine will go up, we call it cardiorenal syndrome type 1 or acute cardiorenal syndrome, has different definitions. The most common one is an increase in serum creatinine by 0.3 milligram per deciliter or more, or the other definitions. The patient might also have, I would say, no major change in renal function or improvement in renal function. Last year or the year before, I talked about the improvement in renal function. This year I'm going to focus on cardiorenal syndrome and type 1. Something that we should all remember is that a patient who comes for acute heart failure comes for congestion, comes for fluid overload. It's not for other reasons like hypoperfusion of the organs. We'll use this concept a little bit later. This is based on adherence history. Well, worsening renal function, or WRF, happens in nearly a quarter of patients who come with acute heart failure to the hospital. What are the mechanisms? Today, we are not talking about the mechanisms too much, but we need a concept, so I'm putting one slide here. You know, when a patient comes to the hospital, from the heart failure here to down here to renal dysfunction, there are at least two mechanisms from a hemodynamic standpoint. One is what we have learned for several years, low forward flow. The second one that has recently been the focus of attention is the backward or high backward pressure, what we call it these days, congestive renal failure, right? It's about the venous congestion in the kidneys. This part here I'm not going to talk about. These are the mechanisms by which the renal dysfunction is giving us worsening in cardiac function. So what is the impact of worsening renal function on the outcomes? For years and years in the medical school, we have been teaching and we have been taught that worsening renal function is associated with worse outcomes. Actually, in this study, for example, the worse the renal function, the higher the mortality, right? Here we look at renal function as a marker of severity of disease more than anything else. Let's take a look at the more recent trials. One of them is the DOSE trial, the one that was 5-6 years ago published in New England Journal of Medicine. It compared strategies of diuretic use in heart failure, bolus versus infusion, and low dose compared to high dose. About 300 patients or more. What we saw here, and I'm going to make it a little bit probably more clear here, yes. So we see that the change in rate between low dose and high dose strategy is different. Well, you give more diuretics, the rate will go down more. That's not really a surprise. The second one is that the creatinine also goes up when you use high dose diuretics. We also have had this experience, all of us probably. What was kind of surprising is this part. Despite the fact that we had more worsening renal function in the high dose group, our outcomes did not change actually. This is another way of showing the same concept. Here we have worsening renal function, but the outcomes stay the same. This is against what we have traditionally been taught, right? Another study is CARES heart failure trial. That was diuretics for acute heart failure. This is ultrafiltration for heart failure. And if you are here on Friday, I'm going to have a talk on ultrafiltration in heart failure. So here we used for cardiorenal syndrome patients either pharmacologic therapy, we call it step pharmacologic therapy, or ultrafiltration. What we found here is that on the x-axis, the weight loss is the same in two strategies. Actually, this has been criticized for this specific finding, but this is not the topic of conversation today. The point is that, as you see, the renal dysfunction is more common in the ultrafiltration group than the diuretic group. This is another way of showing the same thing. As you see, the body weight is the same in two groups, but not the change in serum creatinine. Still, the outcomes are the same. Again, you see worsening renal function did not have an effect on the outcomes, right? This is again against our traditional thinking. This is Escape trial. You all are familiar with this. Several years ago was published. Severe heart failure clinical assessment versus pulmonary arterial catheterization. So here is a post-hoc analysis of the data that was published a few years ago. When you look at the baseline creatinine, it does have an effect on the outcomes. The discharge serum creatinine also is important for the outcomes. But what about the change in serum creatinine, the worsening renal function? The patient has come to you, you have treated the patient, the creatinine is going up. It doesn't have an effect on the outcome actually. Well, so the question comes, is worsening renal function in the setting of acute heart failure always bad? Or is it an additive parameter? Does it have an additive effect on something else that we have been missing for years? Well, this is the study by Dr. Metra, about 600 patients. What they did is that they looked at congestion and worsening renal function, both parameters. And they put these 600 patients in one of these four groups. Either the patient had worsening renal function with congestion, had worsening renal function without congestion, and so forth, okay? Here's what they found. Let's clean this up and make it bigger. The reference group is the group that does not have renal dysfunction and does not have congestion, obviously. The reference group, the best group, right? As you see again, worsening renal function with congestion had an impact on the outcome. But worsening renal function without congestion did not have an impact on the outcome. What it tells us, starts to tell us that maybe congestion is also important, at least also important, at least in this study. This is what they found. They found that worsening renal function and congestion is associated with worse outcomes, but the other three groups are pretty much the same. Now we go to, this is another post-hoc analysis, on the Escape trial. This is from University of Pennsylvania. What they found was that hemoconcentration as a surrogate for decongestion, they used this. So what they found is something that we all know. If you decongest the patient, if the patient is associated, is hemoconcentrated, there will be some worsening renal function. But what was interesting is that this worsening renal function that was associated with hemoconcentration actually was associated with better outcomes. Worsening renal function associated with better outcomes. Think about it. This is another study, but of the same group. Again, showed the same thing. If you have worsening renal function and congestion, you are in your worst shape. The other groups, not so much, even though if they have worsening renal function. Well, this is the latest of this group of studies. It was published about 2 years ago, around 1,200 patients from 6 cohorts. What they found, this time they used serum B-type natriuretic peptides as the surrogate for decongestion. Okay, so actually our surrogates are changing, saying that it's not a matter of how you measure it, it's a matter of the concept. What they found was that this is severe worsening renal function. This is defined as increased by 0.5 rather than 0.3 milligram per deciliter. It does not have an effect on the outcome of these patients. Acute heart failure patients, worsening renal function, even severe worsening renal function, does not have an effect on the outcomes. Yet, the change in congestion or decongestion has an effect. If you are not decongesting the patients, meaning that the decrease in serum BNP is less than 30%, then the outcomes are not as good. On top here is the severe worsening, is the worsening renal function. you see there is no impact on the outcome. But look at the diagrams on the bottom. Congestion has an effect on the outcome. This is showing the same groups of patients, just to summarize the situation. Between congestion and worsening renal function, you have a patient who is coming for acute heart failure, you are using ultrafiltration, diuretics, whatever strategy you choose to use. Worsening renal function does not seem to be as important as congestion. A few years ago, one of my colleagues wrote an editorial. It was saying in acute heart failure, treat the heart, don't mind the kidney. Coming from a nephrologist, it might be a little bit surprising, but I think that is the message. If we have to choose between congestion and worsening renal function, probably decongesting the patient is more important. I say probably because this is a modest increase in serum creatinine. Based on that, this has been the new paradigm that I have been suggesting for a couple of years now. I think we have acute heart failure here, and this is different from the diagram that I showed you at the beginning, which is our traditional treatment. I think congestion is part of acute cardiorenal syndrome. It is a dynamic parameter. It has mutual impact on the renal dysfunction and the heart. It is not just a sign or a symptom. Congestion is a parameter. It has an effect on the outcomes on its own, independent of the kidney function and the cardiac dysfunction. Based on what I told you, I think the impact of worsening function has been different in different analyses, depending on if they have chosen to look at congestion or not. I think that the impact of worsening renal function and outcomes can be affected by presence or absence of congestion. That is the main message of this talk. And I think using worsening renal function alone as an endpoint in studies of acute heart failure might need to be revisited. For example, in CARES heart failure trial, when they saw that the renal dysfunction was more in the ultrafiltration group, they actually stopped the trial. It was supposed to include or recruit 200 patients. After 184 patients, they decided, no, it seems that the renal function is getting worse, let's stop the trial. Now, probably with the information we have today, that study should have been continued, I think. Thank you very much for your attention.